Okay. Thank you for the opportunity to speak. I'll try to not go as fast as I usually go, and we'll make up some time. So I'm just going to go pretty quick. So we're going to talk about early detection diagnosis of cerebral palsy. We've heard some about this earlier today. It's a fascinating field of research, and I start going back to 2008. We saw a lot of these tools described, the Baileys most notably, in terms of this general approach of trying to figure out how can we detect kids early on who need help. So very valiant, great effort to do that. When we fast forward about 10 years in the JAMA Pediatrics, this is the Arena Novak study that had come through and basically recommended to have global implementation as the standard of care, to use some type of a movement analysis to get kids into care early on. I very much like the idea and the sentiment. We're going to go over some of the evidence behind that because, as you'll see. So described as very high quality evidence that you can detect CP as early as 5 months corrected age. And there's a few different scales that are used for different purposes and different age bands. But a lot of this is based on detection of a high risk for cerebral palsy. And so in 2018, when we published our last review on CP, went back into those data and looked at what the recommendation was actually based on. And so the conclusions were largely based on expert opinion, because most of the reviewed studies defined CP in combination with other disorders or didn't actually involve CP diagnoses. And only one of the 12 assessed CP alone. And so the evidence is about children who have a range of developmental impairments or deficits on different core dimensions, but not necessarily having fidelity to the diagnosis of cerebral palsy. So looking now to say, well, is there any progress since our last review in this line of research? And so yeah, there's some good news. There's a lot of studies now that are shifting towards age at diagnosis of verification for CP, including the age 2. So 2 to 3 years is now common, whereas the preceding 5 to 10 years, it was essentially up to 1 year was the common, with no further follow-up beyond 1 year to actually verify CP diagnosis. So age at diagnosis is increasing kind of across the board, although the bad news, most studies continue to be of highly selected high-risk infants, and CP does continue to be looked at conflated with other disorders, which is not necessarily a problem depending on what you're trying to do the screening for. And so the high-risk groups, a lot with congenital anomalies, so-called hypoxic ischemic encephalopathy, folks with neonatal surgeries, congenital heart disorders, trying to look in those high-risk areas. Now, we also have a lot of studies that the primary measure of the impact of the ability to use these movement detections to diagnose or detect cerebral palsy and other disorders are all based on gross measures of magnitudes of association, namely odds ratios. Odds ratios are not good to look at diagnostic performance, because you can have any combination of true positive, false positive, sensitivity, specificity. You can have a myriad of ranges for every single odds ratio. So there is no correspondence between an odds ratio and actual diagnostic test characteristics. So odds ratios are not the way to show us the path forward and give us reliable data about what should be used clinically for detection. We have a long history of diagnostic performance metrics, and we should be using those. Now, those that do use the typical diagnostic performance metrics, they tend to show low specificity, the ability to rule out other things. And so, and this is outside of highly selected high-risk groups, and ranging around 63%, 81%, 82% of looking for highlighted in red and yellow there. So if you take 100% and minus that, that's your false positive rate. So false positive rates can range anywhere close to, above 30% to around 20%. And so we've really got to take note of that and some of these test characteristics with respect to what we're going to do with the kids that we identify and how we identify them. Now, the worst news is that we still have a lot of work to go on evidence that early intervention can actually impact motor function dimensions and how to do that and quantify who can benefit and who can't. So we need a lot more evidence on the intervention. And what we've seen, at least in the systematic reviews on early detection, most of the benefit has come in other domains of neurocognitive functioning, has not been around the motor functioning domain. It's been a lot harder to influence motor function. And so I think there needs to be a bit more emphasis on that, paired with good quality data. So it's not that I want to see kids receiving less services. I want to see good data around lots more kids getting services so that we can make good decisions about what to do next. So as to my conclusion, there's no statistical threshold for diagnostic performance metrics to establish a good screening program. There is no measure or p-value or probability that's going to say this is going to help people. It depends on what we do with the answers of any screening test. And so that's where I'm thinking of. I'm encouraged by a lot of the evidence that there is early detection of a pretty sizable fraction of CP does seem to be in this group. Now, it's not to be the same as cerebral palsy, and we really need to focus on the background probabilities of the children that are exposed to these assessments, because we really want to figure out what is normal development and then what are the different domain-specific trajectories, and focusing on what's in normal populations is probably going to help us with that, and typically developing children and getting a good handle on what is normal and when do we detect changes, and changes within subject-person changes would be fantastic. And beyond, so my gripes early on were usually about the diagnostic performance test characteristics. But then again, thinking a few more years about this, we can't predict much of anything very well, and we don't do so reproducibly. We've got ultrasounds where we try to look at where the small babies are, and it's about a coin flip at mid-gestation. The specificity is very, very low. And the higher you go, the less reproducible it is. So most of the things that we've implemented to help around perinatal care, I don't know any that are really in the last 10 years that are achieving what would be what some say a conventional standard for clinical significance in test characteristics, which is likelihood ratio positive of 14, which basically means that your sensitivity or the amount of the disease or disorder you can detect, it's really got to be above 90%. And then your false positive hit rate has to be far below 10% to get anywhere close to that threshold. And so it's not to discourage folks that are involved in the early detection, it's to get a more acute clarity on what are the test performance characteristics for domain-specific changes, and then what happens when we get kids who have those characteristics into different kinds of treatments to generate the evidence base about what works, what doesn't, and how we go forward. So happy to answer any questions. Thank you.